During a routine healthcare maintenance examination, a 54-year-old woman found to have 2 centimeter left axillary lymph node. 2 centimeter left axillary lymph node. Examination shows no other abnormalities. Lab studies and X-ray of the chest and the mammography show normal findings. A biopsy specimen of the node show adenocarcinoma. Which of the following is the most likely site of the primary cancer? Okay, ready?
Yeah, it's breast. In patients with axillary lymphadenopathy that demonstrates adenocarcinoma on biopsy, breast cancer should be suspected. Breast cancer, the most common non-dermatologic malignancy in women, typically consists of two main histologic subtypes, ductal and lobular, and can present with breast mass or axillary lymphadenopathy caused by underlying occult breast cancer. As in this patient, in patients with axillary lymphadenopathy, mammography should be the first diagnostic step. In negative for underlying mice, a biopsy of the palpable lymph node should be obtained as well. MRI of the breast should be considered following a negative mammogram, as it is more sensitive or specific for breast tissue. This patient chest X-ray um, did not demonstrate lymphadenopathy in other locations, which is reassuring that this patient may have curable stage 2 or early stage breast cancer. With early stage breast cancer, treatment consists of surgical removal of the tumor and axillary lymph nodes along with adjuvant systemic hormonotherapy, biologic therapy, or chemotherapy, which depends on estrogen, progesterone, or HER2 receptor positivity. Patients with advanced cancer are typically treated with life prolonging palliative systemic therapy only. It's not, no, what was the other thing? Cancer of the lymphatic system typically presents as lymphoma and proliferation of neoplastic monoclonal lymphocytes. Primary adenocarcinoma of the lymphatic is not known to occur. Okay. And it's not lung cancer unlikely to metastasize to axillary lymph nodes only. Lung adenocarcinoma may initially metastasize to mediastinal hilar or bronchial lymph nodes, pancreas. Yeah, that's it. Next.
A 32-year-old woman, gravida 3 para 2, comes to the physician for her first prenatal visit. Her last menstrual period is 8 weeks ago. She had a fracture of the right femur. She had a fracture of the right femur 12 months ago that required open reduction and a blood transfusion. Open reduction and blood transfusion. Her current partner is the father of all her children. Examination shows a uterus consistent in size with 8 weeks of gestation. Her blood group is O Rh negative. Indirect Coombs test is positive. Indirect Coombs test is positive for anti-KIL antibody titer 1 is to 256. Which of the following is the most appropriate next step in the management? So
I have no idea. Indirect positive for anti-kill antibody titer. I have no idea. Really?
Yes.
The answer is cell typing of the father's blood. A mother can develop antibodies against RBC antigens after being exposed to fetal blood antigens during delivery or from previous blood transfusions. In this case, the patient likely developed the antibodies to kill antigen after being exposed to it in her blood transfusion. Yeah. Because maternal antibodies can cross the placenta, it is important to determine whether this patient fetus has Cal positive or Cal negative RBCs. Okay. If her fetus has Cal positive RBCs, the antibodies created by her immune system will cause hemolysis of the fetal erythrocyte, leading to severe hemolytic anemia, erythroblastoma fetale, and likely fetal death. As the mother has no sign of hemolysis in the presence of the anti-Cal antibodies, her RBCs do not have the Cal antigen, and she would not have contributed to a Cal antigen to the fetus. Okay. The easier way to determine the antigen status of the fetus is to determine the antigen status of the father. If he's Cal negative as well, then the fetus will be Cal negative and there is no risk for erythroblastoma fetalis. However, if he's positive, there is a possibility that the child will be antigen positive and suffer from erythroblastoma fetalis. 24-hour urine collection measurement and protein and creatinine kinase used to diagnose preeclampsia and diabetic hypertension. However, this patient is only at 8 weeks, whereas preeclampsia presents after 20 weeks. Makes sense. It is not, what was the other one? E. IVIG therapy can be used to treat autoimmune diseases and could have possibly prevented the development of Kel antibodies. If it had been given at the time of blood transfusion. However, it plays no role in the prevention of erythroblastoma fetalis in the setting of active anti-Kel antibodies. Okay, next.
Why it is skill typing of
Which one?
like why it is the answer?
Oh, they're trying to check if the dad has the antigens.
Okay.
Because if the dad has it, then the kid may have it, and then the antibodies are going to go against the antigens. But if the dad doesn't have it, then there is no way the kid has it, so the kid is fine.
Okay.
Next.
An otherwise healthy 24-year-old woman, an otherwise healthy 24-year-old woman come to the physician because she has never had menstrual period. She is 150 centimeter. She is 150 centimeter, 4 feet 11 inch tall, and weighs 62 kg. BMI 28 kg per meter square, breast and pubic hair development, Tanner stage 3. The cervix is visualized and the vaginal mucosa is hypoestrogenized. Vaginal mucosa is hypoestrogenized. Serum studies show luteinizing hormone concentration 22 milli-international unit per ml. FSH concentration 33. Prolactin is 9. Which of the following is the most likely diagnosis?
Okay, they are both fine. Prolactin
Not
is what is
normal.
9.
Prolactin, isn't it prolactin 9 to 20 something?
Yeah, all of them are fine and normal. Which of the following is the most likely
BMI
diagnosis?
is normal. Breast and pubic Tanner station is also estrogen. She has never menstrual.
XO. Mm, is the FSH and LH will be high. Hypergonadotrophic hypogonadism, no, PCOS, um, pregnancy, pregnancy, estrogen will be. I'm between congenital absence of uterus and PCOS. The PCOS, she doesn't have any uh, absence of uterus. Then blah, blah, blah.
She's not that tall. You see, 4 feet.
Yeah,
So is it Turner? There possibility of having Turner?
no, because Turner estrogen will be low. Okay, fine, it's low, and then but FSH and LH will be high.
High. But
Um,
in here, FSH is normal.
prolactin, PCOS. I don't know, I'm between B and F. And we say
Why? Why PCOS?
PCOS, low estrogen, but then FSH, LH will be, no, LH will be high. So it's not PCOS. Absence of uterus, breast and pubic hair, no. Maybe it's that one, I don't know.
Isn't
Okay.
it like Turner syndrome can happen without FSH high?
Oh, can it? Okay, maybe, maybe.
If uterus is absent, then neither of the hormone may be in normal.
Yeah, that's also true. I don't know, just pick one. This one is a bit tricky. Because she has breasts, so estrogen is fine, and she has pubic hair, so testosterone is okay.
Okay,
Anyway, pick one.
Turner can happen.
Yes, Turner. Oh Lord. Turner syndrome is a common cause of primary amenorrhea, okay, which is secondary to ovarian dysgenesis in the setting of 45XO genotype. Other signs of Turner include short stature, okay, she has cystic hygroma, web neck, swelling of the hands and feet, quietation of the aorta, bicuspid aortic valve, fused kidneys, infertility. Additionally, as a result of decreased estrogen, patients fail to develop mature secondary sexual characteristics of breast and pubic hair. I thought she had breast and pubic hair. And stage 3. As well, patients may develop vaginal atrophy, okay, because no estrogen, like postmenopausal patients, yeah. Vital signs will be normal, okay. Diagnosis is made to karyotype analysis. Other labs that may aid in diagnosis are increased concentration of LH and FSH. I thought LH and F, let me double check. I thought LH and FSH were normal. She is premenopause and normal is 4 to 30.
Or like
Oh, wait. Oh, no, she's high. Never mind. She's high. And LH is 5 to 30. What is
L
LH?
LH is normal, but FSH is high. Normal FSH is what?
Well, normal FSH is 4 to 30.
Slightly
Oh,
high, not that high.
okay, listen. Okay, I guess it was high, I guess. As a result of lack of negative, but these findings are non-specific. Okay, they say the findings are it can be high normal. Oh, Lord, jeez. It can be high normal. But it says I saw Tanner stage 3. It goes Tanner stage 1, 2, and 3. 3 is the higher, right?
No, no, 5.
Oh, okay, that's very wrong. Okay, never mind. Okay, so it's not B congenital absence of uterus is because of an error in the normal development of Mullerian system that results in incomplete absence of the uterus and occasionally upper vagina. However, these patients will have functional ovaries and therefore adequate maturation of sexual characteristics secondary, such as breast and pubic hair. Okay, that's why. And it's not PCOS because PCOS most commonly presents as hirsutism, increased body weight, irregular menses because of anovulation, secondary to increased androgen concentration. The LH to FSS ratio is increased. An ultrasound of the pelvis will show numerous ovarian follicle cysts, more commonly associated with secondary. oligomenorrhea than primary amenorrhea. Okay, so secondary oligomenorrhea. In fact, okay, so that's what. Okay, never mind. Next,
A 24-year-old woman gravid to para 1. A 24-year-old man gravid to para 1 14 weeks of gestation for her first pregnancy, comes for her first prenatal visit. She has a history of multiple sexually transmitted disease. Her last tetanus toxoid was 5 years ago. Her 4-year-old daughter developed low-grade fever, respiratory symptom, and a rash 24 hours ago. Examination shows a uterus consistent in size, and 14 weeks of gestation shows consistent in 14 weeks of gestation. Fetal heart tones are hard. Hepatitis B surface antigen assay is negative, and rubella titer is less than 1 is to 8. Which of the following is the most appropriate vaccination for this patient?
surface antigen.
Did last tetanus toxoid. So she has completed her tetanus toxoid.
I
Last,
think so. When does the
like
is every 5 years or every 10 years? I don't know. I don't remember.
you are thinking about booster.
Tetanus toxoid. No, really. I don't. It doesn't make sense because she
If
doesn't get.
if a pregnant lady get all the tetanus toxoid, then she does not need booster as
It
far I
doesn't
remember.
really need a booster. But it cannot be MMR misoma because that's
Live
live,
vaccine, yes.
and it
His
can
hepatitis B is given.
hepatitis B. She has surface antigen is negative, but do we still just give the vaccine for that? I
Rubella,
guess
I
it
think
cannot be rubella because it's. I mean, I don't think so because it's MMR. It's live.
live vaccine. Yes.
Yeah. Okay, so let's do. Maybe it's hepatitis. Let's check. It's hepatitis. Maternal immunization is important for both a mom and fetus. Ideally, vaccination are given prior to conception, but some vaccinations are self-administered during pregnancy. Live attenuated vaccines are made of viable viral pathogens whose virulence has been reduced. However, if a mutation were to occur in the viral genome to revert to the attenuation, the infection could be contracted. Live attenuated vaccines include those with MMR, yellow fever, intranasal influenza, smallpox, varicella, zoster, rotavirus, and oral polio vaccine. Okay. As a rule, dye vaccination should be avoided during pregnancy because of the risk of, although low, of contracting the disease. In contrast, inactivated vaccines are made by killing the virus, which makes it safe to administer during pregnancy. Vaccinations considered to be safe pregnancy are routinely given to all pregnant patients, including the tetanus toxoid, diphtheria, cellular pertussis, influenza vaccine. Additional vaccinations may be warranted depending on the patient immunization status and degree of risk for contracting preventable infections. In this case, the patient is not immunized against Hep B or rubella immunization. Rubella infection, sorry. The Hep B vaccine is a recombinant vaccine with no potential for causing harm in the mother or the fetus and is safe to administer during pregnancy. However, as a rubella part is, okay, we already know it's life attenuation. The patient will also need a Tdap vaccine later in pregnancy, sorry. It's not polio, the inactivated polio or side polio is not necessary in this patient and there is no indication that she was not previously immunized. as in standard. The Sabin polio vaccine is oral, live attenuated, which is contraindicated. It's not, we already know it's not MMR. It's not tetanus toxoid is recommended during pregnancy, but with the Tdap vaccine, not the tetanus toxoid. Mhm. The Tdap vaccine also immunizes against Bordetella pertussis, the cause of whooping cough. This allows maternal antibodies to develop and cross the placenta, providing some protection to the fetus and infant until they can receive their own pertussis vaccination at 2 months. Administration of Tdap vaccines to all pregnant women is an important preventable study. Okay, so we give the tetanus, but not the tetanus toxoid, the Tdap, the vaccine. Okay.
We can give tetanus vaccination, but not Tdap vaccine. That's you mean.
No, we can give the tetanus vaccine, but not the tetanus toxoid, the Tdap.
Okay, tetanus tox.
Mhm. You see here is
Oh,
toxoid.
yes. But after completion of the five vaccine, like five tetanus vaccine, do you we need the booster? Like in case of pregnant lady, you
I thought
got
you I
you
thought you always give to any pregnant lady. You always give Tdap, even if there is booster. I thought it was just one of the recommended. You always give Tdap to every pregnant woman for every pregnancy.
okay.
Or no? Or am I
Even
wrong?
as far I know, may not be. If we complete the vaccination, then we need. Okay, we'll find somewhere else. Okay, no problem. Keep studying. Don't try to be over smart. Okay,
Well,
because this does not work. Every question has uh every question has every clue. Okay. A 57-year-old woman comes to the emergency department because of heavy vaginal bleeding for past 3 days. She has no history of serious illness. Menopause occurred 6 years ago. Pap smear showed no abnormalities. A pap smear showed no abnormality. Physical examination today, no abnormalities. Pelvic examination shows an irregularly shaped uterus consistent in size with a 12 weeks of gestation. Her hemoglobin concentration is 9 gram per deciliter. Hematocrit is 27%. Hematocrit is 27%. Which of the following is the most appropriate next step in the world? Irregular consistent. Okay.
okay. Endometrial biopsy. Abnormal uterine bleeding should be suspected when bleeding is irregular, unpredictable, not associated with usual premenstrual signs and symptoms like bloating, breastfulness, uterine cramps. It may be caused by structural abnormalities such as cervical or endometrial polyps, adenomyosis, endometrial hyperplasia, malignancy, inflammation or infection of the genital tract, coagulopathy, ovulatory dysfunction, endocrine dysfunction, thyroid, whatever, all that. In postmenopausal patient and patients over 45, there is a high risk of endometrial hyperplasia and cancer. The most appropriate next step is evaluation. In evaluation will be endometrial biopsy to evaluate for presence of endometrial cancer. If a patient cannot tolerate outpatient procedure, if the outpatient sample is not diagnostic, dilation and curettage or hysteroscopy can be performed. Hysteroscopy with sampling allows for a more complete evaluation of the endometrium polyps, myoma, structural abnormalities. It's not measurement of FSH will not disclose the cause of abnormal uterine bleeding in this patient. FSH is increased in postmenopausal patient, but it's not useful in the evaluation of abnormal uterine bleeding. In endometrial carcinoma, the measurement of CA 125 can be used for surveillance of patient's disease progression. It's not, where was that? Hysterectomy may be indicated if endometrial cancer is diagnosed. However, in a patient with abnormal uterine bleeding, prior steps need to be taken to diagnose the cause of the abnormal uterine bleeding. Okay, next.
A 14-year-old girl is brought to the physician because of nausea, urinary frequency, and fatigue for 2 months. She has never had menstrual period, breast development, Tanner stage 4. She is 5 feet 5 inch tall. Weight is 59 kg. BMI is 22. Physical examination show no abnormality. Which of the following is the most appropriate next step in the diagnosis?
Nausea
Uh,
and frequency.
for
Mm, mm. Between B and D, measurement of estrogen concentration, fatigue. Uh, do we do a pregnancy? But she's never had menstrual periods. Oh no. Already?
yes,
Okay. So pregnancy, I knew it. Pregnancy test. Clinicians should maintain a low threshold of suspicion for pregnancy in adolescent and teenage patients who are at high risk for unintended pregnancy. Pregnancy should always be considered as a potential cause of presumed primary amenorrhea and should be excluded before considering other causes. Early symptoms of pregnancy include fatigue, nausea, urinary frequency, and irregular menstruation. A careful history should be taken, including of the patient menstrual history, sexual activity, contraceptive use, possibility of pregnancy. During pregnancy test should be obtained if it's possible that the patient may be pregnant. Well, no, it's not CBC. Measurement of serum estrogen concentration may reflect abnormalities in the ovarian production of estrogen and may disclose the cause of primary amenorrhea, such as Turner syndrome. This patient presents with Turner stage 4 secondary secular characteristics, suggesting normal estrogen. Okay. Measurement of FSH and LH may disclose hypothalamic or pituitary disorders that lead to hypogonadotropic hypogonadism and primary amenorrhea. Patients with hypogonadotropic hypogonadism will usually not present with Turner stage 4. Okay, makes sense. Progesterone challenges useful for diagnosing alpha disorders from hormonal causes of amenorrhea. Okay. Okay. Next.
yes. An healthy 22-year-old primary gravid woman. An healthy 22-year-old primary gravid woman, 33 weeks of gestation, is brought to the emergency department because of heavy painless vaginal bleeding for 30 minutes. Heavy painless vaginal bleeding for 30 minutes. Pregnancy has been uncomplicated. Heart temperature is 37, pulse 90, respiration 20 per minute. Blood pressure 120 by 80. Examination shows a non-tender uterus consistent with the size of the 33 weeks of gestation. The vertex is not engaged in the pelvis. Speculum examination shows vaginal bleeding from a closed cervix. Fetal heart rate is 140 per minute. The patient is at greatest risk of which of the following complication?
Do not know. Ready?
One sec. Okay.
So hemorrhagic shows causes of vaginal bleeding in third trimester um, include trauma to the vagina or cervix from intercourse, cervical ectropion, don't know, cervicitis, uterine rupture, placental abruption, placenta creta, increta of the vasa previa, placenta previa. Placenta previa is an abnormal position of placenta such that the placenta partially or completely overlies the internal cervical os. Placenta previa is usually detected on routine ultrasound. Its most common presenting symptom is pain and vaginal bleeding during the third trimester. The incidence of placenta previa is higher in early pregnancy and decreases with increasing gestational age as the placenta migrates up. If mild bleeding from placenta previa may self-terminate within several hours. However, severe bleeding from placenta previa may lead to hemorrhagic shock, which is associated with maternal tachycardia, hypertension, decreased organ perfusion, and organ failure. Fetal distress will generally also be present. Treatment of hemorrhagic shock from placenta previa involves C-section. It is not DIC can be a complication of amniotic fluid embolism, and and occurs because of a pathologic activation of coagulation cascade leading to microthrombi, consumption of platelets, and coagulopathy that is characterized by both thrombosis and hemorrhage. Non-sepsis occurs from severe infection and is characterized by inflammatory and organ dysfunctional state. Pregnant patients are susceptible to several types of infection, including UTI, which may present with fever, chondriomyelitis with fever, tachycardia, and uterine tenderness. Okay,
Okay.
next.
A 32-year-old newly gravid woman comes to the physician with her partner because she has been unable to conceive for 18 months. She has also had moderate dysmenorrhea. She has also had moderate dysmenorrhea and dyspareunia. Mens occur at regular 28 days of interval. Examination of the patient and her partner, including physical examination, semen analysis, testing for chlamydia trachomatis and Neisseria gonorrhoeae, serum urine analysis to document LH hormone surge in phase endometrial biopsy, hysterosalpingography, and shows no abnormality. Which of the following is the most likely associated in this patient's infertility? Okay.
This endometriosis is characterized by the presence of endometrial tissue outside the uterus, and CASIK presents with symptoms of abdominal and pelvic pain, dysmenorrhea, dyspareunia, dyschezia, local inflammatory responses to ectopic endometrial cells cause abdominal and pelvic pain, which may be severe. The pain is often cyclic in response to fluctuation hormones concentration during the menstrual cycle. The standard for diagnosis is diagnostic laparoscopy, which evaluates for visual evidence of ectopic endometric implant lesions and permits obtaining samples for um, histology. Chronic inflammation and scarring of the fallopian tubes leads to infertility and may worsen with in many women with endometritis. Yeah, okay. Want me to read any other answer,
No,
please?
I
No,
don't think so.
okay. Next.
Get the last one. A 69-year-old nulliparous white woman. A 69-year-old nulliparous white woman has a sudden onset severe pain in the upper back. After sitting down, she has hypertension treated with beta blocking agent. She drinks one alcoholic beverage dinner with dinner each night. An X-ray of the spine shows a compression fracture of the 10th thoracic vertebra. Which of the following is the strongest predisposing factor for this condition? Compression fracture. Okay.
Okay. So it is race. Oh Lord, she's white. Osteoporosis is a common condition that is characterized by progressive loss of bone mineral density, leading to decreased bone strength. This decreased bone mineral density often leads to fragility fractures, such as in this patient who experienced a thoracic compression fracture with minimal axial load when sitting. Okay. Osteoporosis and resultant fracture can greatly decrease mobility, even leading to death in elderly individuals. The disease classically affects postmenopausal women with inflammatory disorders and individuals with metabolic and endocrine disorders such as hypercortisolism and hyperparathyroidism. Osteoporosis can be induced by long-term treatment with medication that cause increase in bone resorption, such as steroids. Osteoporosis tend to affect females at higher rate than males, especially those white. Males generally develop higher peak bone mass during the first 30 years of life. Given the chronic and generally linear rate of bone mineral loss, males will tolerate males will therefore retain higher bone mineral density for a longer period, given the higher bone mineral density starting point than females. As testosterone and estrogen both stimulate osteoblasts and increase or maintain bone mineral density, the loss of estrogen leads to accelerated loss of bone mass in postmenopausal women. It is not, where was I? Nulliparity. Nulliparity may be associated with low bone mineral density, but to a lesser extent than conditions that shorten or reduce the amount or duration of estrogen stimulus on the bone, such as early menopause, smoking, low BMI, late menarche. Okay.
So, all the race, not
What do
like
you mean?
any race,
What do you mean? Sorry.
there are plenty of race in the world,
Mm.
isn't it? So,
Mm-hmm.
which race? Is there anything like Caucasian and
Yeah, they're saying white people have more predisposition to osteoporosis, like Caucasians. Yeah. Mhm. White females, I guess.
what? Okay.
Okay, we are done.
Done.
Want to take a break
Yes,
and
we
then
can
we
take
continue.
5 minute, 5-10 minute break and we can start the op 6, the last one.
Wait.